I think I'll take it. So thank you. Good morning, good afternoon, and good evening for us in Europe. I'm from Denmark, also known as the mink country at this point in time. I'm a biostatistician, and I started working in OMERACT back in 2008, and I'm the co-chair of this group of the Contextual Factors, together with Peter Tocqueville and Lynn March. Yes, you can switch the slide, Sabrina. We have an exciting program ahead of us for the next little hour, and as you'll see from the program today, our fellow Sabrina will take us through all the excellent results we've seen already from all the stages of qualitative research and Delphi exercises, and you'll hear about our provisional three core domains for contextual factors. And as you'll learn, we'll spend most of our time on the so-called effect modifying contextual factors. So by the end of the session, we hope you'll find yourself updated with our recent progress and with an improved understanding of the effect modifying contextual factors. And again, yes, please make sure to register, introduce yourself on the chat so that we had it for the notes. Yes, please, let's look briefly on some of the names. As already mentioned, our co-chairs from 3 continents. Sabrina Meyer Nielsen is our fellow, and I would like to give a very strong thank you and acknowledgement to our patient research partners who are making excellent input to the understanding of all these very complicated concepts we're working with. Amy, Esten, Martin, Marieke, Michael, and Nidhi and Pam. And then, of course, we have our methodologist, Bev Shea, who's part of all the meetings we are having at this point. Yes, please change slide, Sabrina. And finally, of course, thanks to all of you who are part of this list. And if you're not on our official name list, just make sure that Sabrina or I or somebody knows about it so that we can update the list. I think it's important after every OMERACT meeting we have. Yeah, I think that's it for now. And hopefully we'll get a chance to discuss all of the things being introduced today. So thank you. Over to you, Sabrina.
Yes, as Robin already said, I'm the fellow of this working group, and I've been it since 2016, and I'm a PhD student in biostatistics and clinical epidemiology from Denmark. But already in 2012, the concept contextual factors was introduced for the first time in the OMERACT process. OMERACT defined a contextual factor as a variable that is not an outcome of the study, but needs to be recognized and measured to understand the study results. This includes potential confounders and effect modifiers. However, the research presented in 2014 revealed that the working groups understood and approached contextual factors in very different ways, leading to great confusion. To address this, our working groups was formed to develop guidance. And in 2018, we are ready to present a research plan. In our first study, we asked the OMERACT working groups to provide published case scenarios. This showed that there were still very different understandings of the term contextual factor. In our next study, we aim to elaborate on the current OMERACT definition to make it more understandable and useful. This included interviews and a Delphi survey. Our interview findings have just been published. In study 2 to 5, we aim to identify a set of important factors that is relevant to consider in all clinical trials within rheumatology. At this point, we have published a meta study for this. But this session will be about the results from study 1B, and now Maren de Witt will tell you about our patient involvement.
Yeah, I think I have been part of the working group and have really enjoyed participation in this working group. And I think it's an excellent example of a project where patients have been involved in a variety of forms. So there have been patient research partners, part of the steering group or the core group. And in addition to that, there was a small core group of 2 or 3 PRPs who really have been working hard during all the different steps in reviewing monthly updates, PRPs have also been involved in a little bit wider context in producing lay summaries and reviewing the glossary, interview guides, and also all the preparatory materials for this SIG session. We had a very special virtual roundtable discussion with 6 patient research partners when we were in the middle of the meta-epidemiological study. And I think we also had a very high participation of patients when we consulted them in the Delphi. The highest response rate in round 2 from this stakeholder group. And finally, patients have also been part of individual interviews in the first study. And I think it's really great to see with how much enthusiasm this working group, and specifically also the fellow and the co-chairs, are working with patient research partners. So I'm very happy to be part of this group. That's it.
Thank you very much. Okay, then we have a little poll. We would like to know which of the materials you used to prepare for the SIG. On our webpage, we had 2 videos, a quiz, a lay summary, a glossary list, and a longer pre-reading text with further details. You also have the option to say nothing of the above. So I see it's coming up, so just please vote. And you can choose more options than just one.
We still need the music while waiting.
I'm sorry, I didn't prepare that.
You can sing, probably.
I'll wait for that. I see
Old MacDonald had a farm.
I see the videos are very popular. I'm happy about that. Great. Okay, we'll move on. So in the next 5 minutes, I'll guide you through the contextual factor types and the main Delphi results. If you have any questions, then write them in the chat and we will answer them in the Q&A session. So from the interviews, we identified 3 types of contextual factors we found relevant for individual trials and described these in detail. These are named effect modifying contextual factors, outcome influencing contextual factors, and measurement affecting contextual factors. We presented the descriptions in a Delphi survey to patients, clinicians, and other stakeholders from many different countries, especially from Canada and the US, as you can see on the map. We were very happy that 43 OMERACT working groups were represented. The top participating working groups were contextual factors, psoriatic arthritis, adherence, and shared decision-making. The Delphi participants provided a lot of great comments and suggestions, and we revised the descriptions based on their feedback and reached sufficient consensus after 2 survey rounds. In the second round, we had 30 patients and 105 clinicians and others completing the survey. We are very thankful for this high engagement. Worth highlighting is the high agreement with this statement. I consider the 3 types of contextual factors to adequately cover the concept contextual factors, and there I can distinguish between the 3 different types of contextual factors. And just to show a few comments from the last round, nice and clear, very interesting and conveniently provided, thank you. And a patient writes, I find this very interesting and satisfying due to the fact that I have felt that something has not been totally satisfying when I myself has participated in different trials. I often make comments regarding these items, not knowing what to call them. Thank you for bringing this up. So we feel we got very far with our descriptions of contextual factors at this point. The 3 types describe different ways that contextual factors can influence the results of a trial. All 3 types are described in detail in our pre-reading material, but in brief, effect modifying contextual factors modify the treatment effect so they can reveal in some patient subgroups experience greater or less effect from a treatment compared to other subgroups, and they're relevant for personalized medicine. And I'll go more into detail with this type in a moment. Outcome influencing contextual factors are prognostic factors, so they predict the prognosis. For example, if osteoarthritis patients have a high BMI, older age, and have several comorbidities, then they have an increased risk of future disability. These factors are outcome influencing contextual factors because they predict the prognosis. Such factors are important to consider in non-randomized trials because they're likely to confound the results. Measurement affecting contextual factors influence the properties of outcome measurement instruments, such as reliability and validity. They can reveal if the instruments perform well across patient subgroups and different situations. For example, a study showed that pain measurements with the best instrument was less reliable in illiterate patients compared to literate patients, whereas the numeric rating scale was not influenced by this. In this case, literacy is a measurement affecting contextual factor for the best instrument. If some of you attended the Equity 6 session, you may notice that this is related to the OFISA equity extension. Finally, to gently guide which possible factors could be considered within each type, specific factors must be either personal, disease-related, or environmental factors. The contextual factor types are not mutually exclusive, so some factors such as sex may both be effect modifying, outcome influencing, and measurement affecting contextual factor. Since we only have limited time today, we'll only focus on effect modifying contextual factors for this session. So, in the next 5 minutes, I'll go into detail with this. You may recognize this example from our pre-SIG material. Patients with rheumatoid arthritis are randomized to a drug or to placebo, and from the results it's clear that more patients are responding in a group receiving the drug. Now the question is whether the chance of responding depends on certain characteristics of the patients. In a study that divided the patients in both groups according to disease duration less than 10 years or 10 years or more. And as you may remember from our pre-SIG materials, that the patients with longer disease duration have more benefit of the drug because the difference between the drug and placebo is much larger for this subgroup, whereas patients with shorter disease duration does not seem to have much benefit. In this example, disease duration is an effect modifying contextual factor. It fulfills all the key criteria. Disease duration modifies the treatment effect. It is measured at baseline of the trial. It is relevant for personalized medicine. Disease duration could be used to identify patients for treatment. It fits within the classification categories. Disease duration is a disease-related factor. And finally, it is possible to measure. This example is very simple, and you can easily imagine other factors in place of disease duration. Why is it important that we consider effect-modifying contextual factors? As we saw in the example, this can lead to important knowledge for clinical practice. However, analyses of effect modifiers are not routinely reported for trials, so facilitation is needed. How should these factors be accounted for in trials? Since this is based on a statistical concept, effect modifier, there exists a lot of guidance already. But what is lacking is clear guidance for which contextual factors should be considered. We are in the process of developing a generic set of factors that are usually suspected or frequently shown to be effect-modifying contextual factors. At OMERACT 2018, we developed a provisional list, and other good suggestions that overlap with this list is the FDA standard factors age, sex, and race, and the Progress Plus factors for social inequity. OMERACT working groups can use this future generic list and possibly add disease-specific factors. My last slide will be a few points about what you need to know about contextual factors, effect modifiers. Effect modifiers is a huge topic, but I'll try to keep it simple. When a factor modifies a treatment effect, it means that the treatment effect depends on this factor, like we saw in our example. To assess whether a factor is an effect modifier, you look for a so-called statistical interaction between the treatment and the factor in a statistical model. If you're not familiar with statistics, you just need to know that these tests are important, and they're usually referred to as test for interaction, test for moderators, test for subgroup effect, or similar. Most trials do not include enough patients to investigate effect modifiers. A rule of thumb is that the number of patients that is needed for investigating effect modifiers is 4 times the number that you need for investigating just the difference between 2 treatments. Also, there is a risk that significant findings may be due to chance if many factors are tested in the same trial. In our example, the trial investigated 12 more factors. However, trials should report estimates for subgroups anyway, as the results can be combined in a meta-analysis of several trials, which then reaches enough patients, and chance finding may be less of an issue. So, our focus is that trials, by default, to report their results according to potentially important contextual factors, for example in an appendix, to make this data available for future meta-analysis. Now there is some time for a few clarifying questions. And Marike, she's keeping an eye on the chat. What do we have?
We just have one. Hi everyone, by the way, and perfect presentation, Sabrina. Thank you. We just have one question from Diana, and she says that she asks, effect modifying and outcome influencing are both variables that influences outcome. Is a difference regarding to the outcome that with the EM, the aim is to analyze its effect, and with the outcome influencing, the aim is to adjust for its effect? That's the question. Anyone care to answer?
If I go back to my slide, I think I'll just start right there. Here we have this overview there. So outcome influencing are factors that predict the prognosis. So that's not necessarily something about treatment, but what happened, what will happen with the patients over time. Where effect modifiers, it will be about what modifies the treatment effect in a randomized trial. I don't know if that answers the question. Otherwise, others can pitch in.
Sabrina, maybe it's helpful to remind people that in a trial, we're always talking about net benefits or net harm. So you subtract the effect of the intervention and the comparator group, typically placebo. So that's always about net benefit. And in many cohort studies, we simply measure what happens over time, simply a change. So that's why we separate it. So the first one is mostly for trials.
Okay, Sabrina, I have another remark, another comment from Loreto. She has a concern that each therapy may need different effect modifiers. Like, for an example, biomarkers like levels of IL-6 prior to the use of IL-6 blockers.
Yeah, that's a concern we often get, that well, there are factors, well, they are specific to treatment, but what we are trying to look for are effect modifying contextual factors that are usually modifying the effect of treatments. So across treatments.
No more questions. With very clear presentation. That's the conclusion then, I think.
Oh, there we are. No more questions. I guess we can move on then.
Maybe it's good to say, keep asking those questions in the chat as we proceed.
Yeah, sure.
Because it will be very hard with a group of 45 to give everybody a chance to say something. So put it in the chat, and then we'll be monitoring and discussing the questions as they come on.
Sure. So I move on then.
There's another question.
Oh, yeah, sure.
People are getting enthusiastic now after this comment from Maarten. From Lorna, what about individual absorption of, for example, a drug? Maybe Lorna likes to clarify a little bit more on that question.
I find it quite difficult to get my head around the differences, and if you had a large number of patients in a trial, but their absorption of the drug varied, and you didn't necessarily know that there was this differential absorption, how can you pick out that? How would you classify that, and how might you realize that that was affecting your outcomes?
That's a good question. I'm not sure I can answer that. How you would notice that. But
well, maybe I don't know an example about absorption, but there's all kinds of ways that you can have difficulty metabolizing the drug. So your drug levels would be much higher than in someone who metabolized it well. And on the other hand, you can have very good liver enzymes so that you metabolize a drug very quickly. So depending on the kind of drug, you can either be over or underexposed to the drug. So that is a little bit similar to your question. And I think you could say if this is a major problem with that drug class, then it would be an effect modifying contextual factor. But it's like the other question, it's usually limited to one drug or certain types of drugs. And that would make it interesting to study in trials that are looking at that drug. But the object of this group, I think, is to see whether there are factors that are so common across different types of interventions in a disease that you want in your course set to say, well, it's probably important to make note of these factors as you set up your trials, to make sure you measure them so that you can report subgroup analysis, which makes them, you know, like big things like sex and age or disease duration, that kind of factor. All the other factors are important in specific settings. That would be my response.
And if I may add, this is Robin. Also, I think the question about absorption and stuff, that's that would change the entire paradigm probably clinically. So that we will never stop any research initiatives looking into these things. So that's why we start with the generic thinking. I guess if we find a biomarker that could be, for example, absorption, that would be highly important, and that's why we call it personalized medicine. But so far, we haven't seen a lot of good signs in rheumatology, to be honest. But in the literature about these effect modifiers, people keep mentioning breast cancer having good biomarkers on who should have which therapies after getting the diagnosis. So rheumatology research is just getting started, I would say.
Okay, I have more comments now on the chat. I have a question about what about treatment adherence as an effect modifier? From Maria, as a question.
Yeah, we tried to investigate that in our meta-epidemiological study, as I remember. So the challenge was that it was something that needed to be measured at baseline for being an effect modifying contextual factor. So that was hard to find in the trials because it would usually, so people's general adherence to treatments, I guess that would be when it's measured at baseline, where usually the trials would measure the adherence to the treatment after baseline. That, yeah. But I see it as a contextual factor.
Yeah. And I have another one from Dorcas. How much of a barrier is the need to have 4 times the sample size in order to evaluate an effect modifier contextual factor?
Can I get that one again, sorry?
How much of a barrier is the need to have 4 times the sample size in order to evaluate an effect modifier contextual factor?
that is a barrier, a challenge. Yeah.
Yeah,
It definitely. I mean, I guess that's a huge challenge, and that's why we want people to, even though they don't have the power, they don't have enough patients, they should still report just from normal trials that are not powered to look at effect modifiers. They should still report the subgroup effects, so it can be collected in a meta-analysis, and then there will be enough patients.
And also, I think we are saying here that people shouldn't be blamed that it's quote unquote underpowered. If we make it a mandatory requirement to have an appendix with these analyses, people shouldn't worry too much about the statistics per se.
No. Okay. I also have a question here about what if there's a factor that doesn't modify but enables the effect, but already people are answering this question and they think it's also an effect modifier. So not only modifying but also enabling the effect. With some examples, maybe we want to talk about that, or are we accepting all the answers? I think they are right? Enabling and modifying, both for effect modifying. Sabrina?
I'm not sure I understand. Maybe somebody else will pitch in here.
Yeah, I mean, I agree with Mariko has picked up on that. The effect can go in either direction. It can make the treatment look better or the treatment look worse. And if it's modifying it, then it's important to measure. Yeah, I think that's what they meant. I'm not sure if that explains it, but
yeah, I agree.
Okay. Okay. No more questions, Sabrina.
There's a lot of great questions and comments, and obviously we'll copy all of those and we'll save all of those and respond to them.
The question is the difficulty in identifying them, and in fact identifying whether they quote help or hurt.
Well, now that we've got these lovely definitions, I hope everyone will be looking out for them, and when they see examples, shoot them through to Sabrina so we can be collating them.
I have one from Loretta. How do you test an effect modifier with a continuous variable? A statistical one.
That's a really good question. What I see that for example, FDA summaries too are that they, for example, with age that's continuous, then they would put a limit that, for example, below 60 years and above 60 years, and then they have the subgroups that they can use. Yeah, that would be a way, but of course it will be a challenge to find a good cutoff. And yeah, and that might be, yeah. So that might be some challenges to this. But good question.
You already said it, Sabrina. I mean, it's the interaction factor, so that can take care of continuous variables as well as dichotomous. But then we're going into statistics, and like Robin said, who is a statistician, we shouldn't worry too much about statistics. Let him worry about it.
So this is George. Yeah, you're absolutely right, Martin. You can build it. You can build your you can build your interaction term right into your model and just test it whether it's binary or continuous. You should be okay. And Sabrina, that would then save you making this big decision of what the threshold is, high and low.
Yeah, sure.
Anything else in there? No. You can probably move on, Sabrina.
Yeah, sure. Yeah. So now it's time to look at the examples that we have got. We got 8 examples. 5. Yeah, sorry. Yeah, so we got 8 examples in, and 5 of them were excluded because they had no test of interaction or they were about instrument rather than effect modification. And I will introduce the 3 selected examples, and there will be some time for discussion. And listen carefully because I will only use 1 minute on each example. So, example number 1 is a multi-center trial of patients with systemic lupus erythematosus and lupus nephritis. SLE is an autoimmune disease causing damage to many organs such as skin and joints, and lupus nephritis is a frequent complication where the kidneys are affected. In the study, they randomized patients to 2 different drugs, MMF and IVC. After 24 weeks, there were no difference between the 2 groups for their primary outcome, which was improvement of kidney function. However, when they divided patients in both groups according to race, they found that MMF was more effective compared to IVC for Black and others. Here, race is an effect-modifying contextual factor. Example number 2 is a trial of patients with knee osteoarthritis. In the study, they randomized the patients to either exercise aimed at strengthening the muscles on the front of the thighs or to control treatment where they had no intervention. After 12 weeks, there was no overall effect and no interaction for the primary outcome, but there was an effect on a secondary outcome, stomach pain, where the exercise had reduced the pain compared to the control treatment. And prednisolone, or to cyclosporin and placebo, or to prednisolone and placebo, or to receive placebos for both drugs. The primary outcome was radiological damage after 24 months. In a secondary analysis, the researchers divided patients in both groups according to their ACPA status. ACPA is a disease-related biomarker for rheumatoid arthritis patients. They found a significant interaction of ACPA status, and this is especially clear when you compare both drugs with both placebos. Among the ACPA positive patients, the high radiological damage in the control group seemed to be prevented by the drugs, whereas ACPA negative patients does not seem to have much benefit. So here ACPA status is an effect modifying contextual factor. So now there is some time for discussing the examples, whether you find clear or useful for explaining effect modifying contextual factors, and Maren Boers will be ready to facilitate, and Maren de Witt will be reporting from the chat.
Yeah, okay. I think, Dorothy, everybody has very nicely listened to your explanations of these 3. There are currently no questions in the chat. So I propose you can add your questions in the chat, or you can unmute yourself. That's also possible. So we have a response. There's one person who says, everything is very clear to me. And then there is a comment from Loreto, who says, most examples do not test the interaction. They just divide results into groups.
Okay, so I think the issues about testing, etc., are focused on proving that such an effect is there, and the examples are just showing how this would work, and the focus of the SIG is actually to make people aware of these 3 types of which we are discussing one, and to think about how we would look for such factors when we start making core sets. So it's not about proving that it is there, but suggesting effects that might be useful to take along when you start planning your trial.
Also, Martin, if I may add, I think that historically speaking, speaking to Loredo's excellent point, for many years we have seen people using subgroups as a trick to massage the data to find a statistical signal, and that's clearly not what we are communicating here. We're just saying we need all these, let's say, sub-analyses in an appendix, because clearly the journals won't like all these extra tables. So it's just a reporting framework that we hope that the OMERACT community will support, independent of statistical significance, full stop.
I think there are people who are confirming that the explanations and the examples are very clear, and they throw a little bit light in the darkness. And Niti also indicated that in the examples there are p-values, but Loreto also indicated that she was referring to the examples outside of these examples. And now there is a question from Dorcas. If one saw these subgroup differences, am I right that there would also be an interaction effect that was significant?
Yes, I think the answer would be yes.
Either that or what we call a type 2 error, that the subgroups are not large enough to show it. So it might appear very clear to the reader of the paper, but it could be that the subgroups were too small. Maybe George could speak to that.
Yeah, certainly, Robin. So you're absolutely right. So this goes back to you need 4 times the sample size to find the p-value for interaction. And you do have a power issue. You do have a type 2 error issue. In fact, New England Journal of Medicine now, they would like you to identify, using confidence intervals or whatever, what the subgroups would look like, but they do not want you to put in the p-value anymore. So they realize that there is a power issue.
There is a suggestion from Niti, who refers to and suggests to use forest plots as a way to present the data in one table.
And if I can, Martin, going back to that, that's how we usually present it, as a series of forest plots, where you have the comparison of your 2 groups, by this subgroup, and this subgroup. And we always used to put the p-value at the end, the p-value for interaction. And as I mentioned, we just went through a publication with New England. In fact, we just did the galleys 3 days ago, and we had to take all the p-values out and just give the forest plot itself, going back to what Martin has said about the power issue and the type 2 error.
And George, or Niti, maybe can you just very briefly explain what a forest plot is? That's one of the questions from one of the PRPs.
So I'm not, maybe someone else can diagram it better, but basically you have a line at the bottom. It says favors treatment. Maybe your line is at the middle at a 0 point, and then you say the right side is favoring treatment, the left side is favoring placebo, and then you show the results for each of the subgroups as a dot based on how well it favors placebo or favors treatment. So you can see all the different subgroups on that table just with a dot, and then the confidence intervals are a line that goes through the dot, so that you can see how good or not good the subgroup seems to be favorable. So if the line that extends from the dot itself crosses 0, then, you know, basically we say there's no evidence of an effect. That's not true. It may, to the earlier points, may not have been powered, but I don't know if someone can pull up a quick picture of a forest plot. It would be a lot easier if you could see it.
Yeah, yeah, I found one.
If you Google forest plot, you'll see a picture. Yeah, that's a forest plot. So.
It's just a random one. I don't know what it's for, but yeah, there you have the estimates. But I mean, this is not for subgroup effect, so I should probably find.
You can find one. Yeah.
Yeah.
That's the meta-analysis, and we use this a lot in meta-analysis in Cochrane. And forest was named after a person forest, not actually a forest like it looks. So, but we use that a lot in the Cochrane collaboration meta-analysis. Pull up the subgroup. Pull up yours, Sabrina.
What?
Are you going to pull one up, or do you want me to?
If you have one, please do it. That would be great.
Okay, we'll look while you continue on, so we can put it in the chat then. Okay.
There was a question from Robin. Can you speak to the difference between qualitative and quantitative interaction?
Yeah. I guess it's me.
I typed it. I already typed it in.
Martin, you should read out your message there, though.
So I said, probably, Robin, you can answer that better than I can, but quantitative is that the effect is in the same direction, for example, improvement, but one subgroup has more improvement than the other, and qualitative, this is a type, qualitative is that one subgroup improves, but the other deteriorates.
I agree completely. I just think it was important to bring it up there, that it could actually potentially be in completely opposite directions. So that would be a very informative subgroup if we had that a qualitative interaction.
And why do they call it a qualitative and quantitative when that has such a different meaning in some?
Point. Back to George.
Well, sorry, I'm trying to take myself off mute here. I thought the explanation that Martin and Robin gave were good. So quantitative, it just differs in degrees, if you wish, quantitative degrees, whereas qualitative, it's a sharp difference, so that you can say this is quite different than that one, that type of idea, as opposed to certain degrees. I'm not sure if that helps the explanation, but I'm not sure what the original reason why they put those particular labels, but that's the way I remember it.
But with qualitative, the sign turns around. So
exactly. It's
the whole quality of the interaction changes, because now you're not increasing an effect, but you're seeing the opposite effect. I think that was what's meant.
Yeah, so no longer is it just simply a degree of change, it's a dramatic change when you go to qualitative. Yeah. And as you say, Martin, it could be a complete sign change.
Can I ask the group to think about, suppose that we're just talking about the effect modifying contextual factor, and there's the other two, so there's three of them, and we understand all this. So how practically would we go about identifying important contextual factors to nominate for inclusion in a course set? I'm not talking about core contextual factors, because that's probably some 10 years off before we get that decided, but important. So how would we go about defining which contextual factors would be important and would be, good to include in your recommendation when you make a course set? How would we do that?
If I can start, Martin, I think that one piece of advice we have been discussing, and also in the materials, is that I think that any person in rheumatology research at this point should know that EMA and FDA already recommend some. So I think, and I, for example, didn't know of their guidance, but people who work with these authorities, they would know how to do it already. So that's for one thing, that's informative to me. So there are lists out there that the authorities expect to see. And then of course, like ACPA positivity, that's a disease specific issue.
Another question, I think, by Karin here, which builds on that, is, so what happens if you identify potential contextual factors, does the group then need to prove that they are really important before they can be confirmed? I'm not sure that is fair to ask of a group making a course. That I think they can nominate those factors and put it on the research agenda, which doesn't mean that they have to do all the work. That would be my answer to that question.
I think there's also a second question that Carina raises. That's a long question. If an intervention gives a different results depending on how it's characteristic, for instance, a patient decision aid with lay language versus a decision aid with more complex one, could there be a contextual factor involved, or do you need to have a different impact on various participants depending on the level of socioeconomic status, for example?
I think this is moving on to the outcome measurement modifier, outcome modifier, and along the lines of what the equity group were also discussing, sort of how you might respond to a different instrument based on health literacy or background or context. So then it becomes an outcome modifier rather than an effect modifier necessarily. It's modifying the outcome measurement itself rather than the response to treatment. I don't know, I guess they're interacted there.
I think we call it measurement affecting contextual factors. Yeah. I agree.
Yeah. I think the main thing about this is that we're trying to get a standard definition so that we, and then if we've got multiple examples of what might be covered into that definition, I think could be helpful going forward.
And also, I think it's important that we are hoping that all individual working groups in OMERACT will take on the co-responsibility of coming up with their, since, as Martin is saying, they are doing their own course sets for each condition, they should also have a look into, let's say, the ACPA example, if that's relevant to their specific condition. So we'll just put up, let's say, the generic framework, and then, of course, more work needs to be done. But every single working group are not only invited, but they're supposed to be interested in this while they provide their core outcome sets in the future. For example, imaging and biomarkers in general.
Okay, there are a lot of different lines in the chat going on. They look at the different examples and responding. They are about the ACPA, the questions about what ACPA is, but also people asking whether ACPA, where is that question, that comment? Well, I don't see it anymore. Richard suggested example of mechanical ventilation affecting response to dexamethasone in COVID. That had to do, I think, still with the with which example? Richard, are you able to clarify your comment?
Dexamethasone has detrimental effect in patients with COVID who don't need oxygen, while positive and extremely positive effect in patients treated with oxygen. So it's about disease severity or phase of the disease. So I think it is an example of qualitative factor. Okay. Could you hear me?
Yeah.
It's not rheumatology though, but
it's a nice example.
and highly timely.
Yeah.
I think it's another example indeed. There's a question whether it's indeed a limitation of clinical trials that normally men of certain age are more included. So that makes it difficult to identify age and gender as an effect modifier.
I guess that's an important point, that if we do have a generic set of modifiers, and if the FDA and EMA have those, then it behoves the designers of trials to make sure that they have sufficient subsets of those contextual factors included. So I think this can only enhance future generalizability of the data if we state it up front.
Well, I don't think that's necessarily true. I mean, the trial population is really dependent on the question you're trying to answer, and it may be very relevant to include only white males of a certain age. So I wouldn't, presuppose that you have to be a representative in your population always. It really depends on.
There's many trials that I'd agree with that. There might be occasional questions that are only but
So I was just going to go back to that point about mechanical ventilation and dexamethasone. The trouble with that, of course, is that mechanical ventilation itself is not a fixed factor. It changes during, the course of treatment with dexamethasone or the other way around. So that would be, it wouldn't be a thing you only measured at baseline. So that's making it a little bit difficult. Robin, George, what do you think?
George?
Yeah, sorry, Martin, I was on mute. Yeah, I agree. Yeah.
There's also an interesting question from Annelies Bonen from Maastricht. Should we make a difference between pharmacological and non-pharmacological interventions or interventionists when trying to identify contextual factors?
My take on that, Annelies, if I can try answering it, that there will be obvious examples where it's important, such as like if we intervene with antibiotics, it's important to know whether it's a bacterial or a virus, and then bacteria and virus would not be important if we are just testing out, insoles in osteoarthritis. So I lost my. Yeah, so whether it's in what kind of drug it is, that would also, that's contextual too. So if it's a disease specific contextual factor, then of course it's dependent on the intervention too.
I also think that when we stay to inflammatory rheumatic diseases, that for a pharmacological intervention, things like the type of drugs that you failed or ACPA positivity, that they might heavily influence the outcome, but ACPA of a pharmacological intervention or drug intervention, but it's very unlikely to influence the effect of a non-pharmacological outcome intervention, while, for example, education might be very relevant in most non-pharmacological studies, or the way you yourselves have self-management skills. So I'm not sure that we can identify a lot of universal effect modifying contextual factors, and we might miss important ones if we don't link it to specific interventions.
So I guess we only have 4 minutes left, I think, there. So I see on the screen already, we've got those 2 questions there, whether people, there's a lot of fantastic chat around statistical methods, and I think it's going to be really useful, and we'll take that on board in our summarizing. But I guess at this stage, do we have a vote for this, Sabrina? Like, do we find the examples clear and understandable, or example?
We have an overall vote that I can put on. Yep, the last one, yes. So that's a more general vote, a general questions saying, do you feel that you understand the concept of effect-modifying contextual factors? Just not at all, or just a little bit, moderately well, or very well? And the second question says, do you think the key criteria are helpful to identify effect-modifying contextual factors in a randomized controlled trial? Not at all, just a little bit, moderately helpful, or very helpful? That's very nice. None or almost none or not at all or just a little bit.
Okay.
I think, yeah, we think we should go to the wrap up. Yeah.
Okay, well, thanks everyone for participating. Congratulations, Sabrina, very nicely presented, and that's a nice result that people have found them very clear and they're good examples. Lots of great input from everyone and discussing there, and clearly there's a lot of good thought going into this from everyone. So if you aren't already listed in the working group and you've been participating today, or you know other people would like to be ongoing with the working group, Sabrina sends out very nice updates regularly as she progresses the work. So please get in touch with us after this if you're not already there. And as you start seeing more examples of these types of contextual factors, please also collect those and send those through. But congratulations again. Thanks everyone for your participation and coming on board, and well done, Sabrina. Great work, Robin and Martin, Marika and Bev, and of course Shauna hosting us there, keeping us all on track. So thanks everyone.